Okay, just copy the link if you want to email that to yourself.
We'll start in a second.
That's
I can give you some more.
No, I've got one. You can ask a question.
Yes, go ahead.
What software do you use for cartoons? BioRender or
Canva.
Canva?
Yeah.
Oh, thank
All right, guys, grab your seats. No lunch will come in late. I'm just kidding.
Are you putting that slide up? The first one? Oh, that's.
Do you have slides?
Yeah, it's the same.
No, I don't.
Okay.
But yeah, I'm starting with a picture of him.
Yeah, we could put that. Yeah, we
Did you know him?
No.
Yes, I did. Check one, two.
Okay.
I didn't actually work with him. I just knew him from the movie. Okay, so we can go back to the PowerPoint?
Yes.
Okay.
And
Oh, wait. Yeah, perfect.
Do you want to open up the first slide there? So that it's full screen? Okay, great. Yeah. Oh, this is your slide advancer.
Okay. Oh, thank you.
Do you want to sit down while I say this and then come up?
No, no, no. I'll just,
No.
you know why.
All right. Good morning, everybody. My name is Laura Collins, and I'm the Vice Chair of the Division of AP here at BIDMC. And it's my distinct honor this morning to introduce the Harvey Goldman Memorial Lecture. Dr. Goldman, as I hope many of you know, was a giant in GI pathology and a long-standing member of our department here at BIDMC. Harvey was a professor of pathology at HMS and at Harvard Medical School, Massachusetts Institute of Technology Division of Health Sciences as well. He served as the chairman of New England Deaconess Hospital, and then when the hospitals merged, he served as senior pathologist and vice chair of Beth Israel Deaconess Medical Center. Harvey was really the quadruple threat. He was teacher and mentor, clinician, clinical researcher, and administrator. But really his great love was mentoring and teaching. And he was a master educator as well as being an outstanding pathologist. And so I am proud today that Drs. Deshpande and Vyas are continuing this legacy of great GI pathology in our department here with this inaugural CME course. And thank you to you attendees for joining today. So it's really fitting that our first speaker for this memorial lecture should be Dr. Elizabeth Montgomery, who is professor of pathology and vice chair at the University of Miami Miller School of Medicine. Dr. Montgomery completed her medical degree at the George Washington University, followed by pathology residency at Walter Reed Army Medical Center, and then serving at the Armed Forces Institute of Pathology until 1992, where she then joined the faculty at Georgetown University with joint appointments in pathology and gastroenterology. She then was recruited to Johns Hopkins, where she was on faculty for a couple of decades before moving to her current position. Dr. Montgomery, as I'm sure you're very well aware, is an expert in both GI pathology and bone and soft tissue pathology, but she's here today in her role as expert GI pathologist. She's the author of many scholarly publications on GI and esophageal pathology, as well as bone and soft tissue pathology. She lectures both nationally and internationally on these topics, and she's the recipient of numerous national and international awards. She's a great mentor and teacher and a generous colleague and friend. And so it is with great pleasure that I have the honor of introducing Dr. Montgomery today.
That was very nice. You're going to be so disappointed after all that nice stuff. And what she didn't mention is look how handsome Harvey Goldman was. But this is going to be the grouchy old lady's viewpoint. I have to throw in this picture because at the last USCAP meeting, Dr. Rhonda Yantis and I both had Harvey Goldman Awards. Hers, of course, was far fancier, but we bought gold dresses in honor of this. All right, so let's get back to basics. We're talking about stomach polyps, and I'm a grouchy old lady. And I'm just, going way back to basics just to remind us about the different spots in the stomach that you know. And why can't I make the mouse work? But I guess that's why God made arrows. You can see that the fundus corpus and antrum are marked as our other anatomic landmarks. And of course, they're super important because the site in the stomach determines all sorts of things. So if we open up a stomach, we have more of the same. What I want you to notice is that the folds are much more dramatic in the body. Oh, good, now it works. And you can see in the cardia, you don't see them as much. And down here in the antrum, they don't show as much either. All right, so let's start with a case to talk about a topic that just flocculates my colloids at times. It sounded good, right? It means gets my knickers in a twist. So a biopsy was performed of a gastric polyp from a 55-year-old woman. She had a long autoimmune type history and a diagnosis of cancer was made. And luckily, they did a limited resection of her gastric body because on imaging, the lesion only involved the mucosa and submucosa. Now that would be treated endoscopically, as we just heard, for the esophagus. So here's the lesion. You can see. Oh, what did I do wrong?
Oh, no, nothing you did. I just have to go in. And,
Okay,
yes.
sorry. Usually I manage to screw up all this kind of stuff.
No.
It's because I'm so good looking.
Anyone have a good joke? I can do a body dance.
Ooh,
No, I can't.
are you going to do interpretive dances of a
Pull
polyp?
up the presentation now, I think.
Okay, so where's the little?
There's a little bit of delay, but it should be.
It's working?
Yes.
Yes. Okay.
Wonderful. Sorry about that.
All right. Oh, minor detail. Yeah, you guys don't need to say that. You can just live stream. All right, so here's the lesion. You can see that it kind of is at the junction of the mucosa and the submucosa. Here's our muscularis propria. And it would now, of course, have been managed with an endoscopic technique. But I draw your attention to the background flat mucosa. Ooh, ooh, ooh. All right, so here is, oh my goodness. Here is kind of part of it. You can see this is supposed to be in the gastric body, and there's no oxyntic mucosa, and you can see the little top of the lesion down at the bottom of the image. Here it is. And where are the parietal cells? So, of course, this is a gastric neuroendocrine tumor of enterochromaffin cell-like or enterochromaffin-like cell type. And it's associated with autoimmune gastritis and hypergastrinemia. And these things behave very, very indolently. So let's talk about NETs because I hate them. Let's talk about the glorious past. It was so easy. There were carcinoids, there were small cell carcinomas, and everything was fine, right? No problem. We were a little naive. We had a delusion that small cell carcinomas were just high-grade carcinoids, or at least I did. And then the pancreatic pathology colleagues started to study pancreatic lesions. And that's because in pancreas, there are only 10 entities. So you have to study each one in massive detail. Okay, so then they began to realize that counting was good. They formed the counting club, and you were supposed to count mitoses and then Ki67 labeling. And they called it NETs instead of carcinoids because, well, NETs, it's a good acronym. So why would you say carcinoid? So all these data began to evolve over pancreatic data, and they really were excellent. So, what the colleagues realized is, oh my gracious, neuroendocrine neoplasms or NENs had to be separated into NETs, tumors, and NECs. And you all know this. I'm just going back in history. And this was by edict based on pancreatic data, magically applied to all sites. And it probably works pretty well. So you could either count mitoses or add Ki67/MIB1, and it more or less worked. NETs usually were not very proliferative, a couple of percent, and NECs were ragingly proliferative, 80 to 100%. And so back in the day, when this started, if something looked like a NET, but oh gracious, it's moderately proliferative, oh gosh, 20 to 30% by Ki67, we called it neuroendocrine carcinoma, okay? And we were fine with that. We were happy. But then the pancreatic colleagues had been busily sequencing everything they could get their hands on. And what they learned is if you looked at these carcinomas versus NETs, you had a very different mutational panel. You had your KRAS up in your carcinomas. Sometimes you had your SMAD4, even in these neuroendocrine carcinomas. And you almost never had alterations in DAX or ATREX or MEN1 gene or MEN, sorry, I'm in the wrong column, but basically you had either a P53 type arrangement in small cell and large cell carcinoma, and essentially never in the well differentiated lesions. Okay, so then in 2007, folks realized, oh my gosh, let's look at the data. NETs and NECs were determined essentially to be unrelated lesions, but the terminology and reliance on proliferation indices can actually make things worse. However, we need to get these sorted out. So the new recipe developed in 2017 was you had a grade 1 through 3 NET with NET morphology and various proliferation indices versus NEC with different morphology and a high proliferation index, which is usually just way treetop high. All right, so there's different treatment. There are not that many data concerning G3 NETs elsewhere outside of the pancreas, but the concept is recent, and we've tended to extrapolate data from pancreatic well-differentiated or islet cell NETs. And in difficult cases, you can try some stains, except anybody who's had this dilemma has realized it's a struggle. You're looking for DAX and ATREX loss in some NETs, and it's only like 40% for each of them. P53 can help you. We've just heard from Dr. Deshpande that P53 is great for some things, and you can look at RB protein, which is lost in NECs. There's a recent paper from Sarah Umetsu, and she pointed out that, in fact, you can use good old-fashioned P16 to help you confirm NEC, but I don't know that that's going to hold the test of time. Same with sequencing. It can sometimes point you, but it doesn't always work. All right, but you kind of got to try your best because, of course, G3 NET is treated with somatostatin analogs and mTOR inhibitors and alkylating agents, whereas NEC, big guns, platinum-based chemotherapy. So we need to try our best. We don't always do it. All right, does anybody here like counting Ki67? No, you don't. So if you ask a machine to do it, it counts lymphocytes. Oh, but I can't tell either, right? You get that brown thing. I can't tell if it's a tumor cell or a lymphocyte. But machines are more impatient than people. AI is supposed to solve it, but who has that? Nobody does. But there's a poor man's trick I'd like to show you. And in fact, I went digging around in the machine algorithms, and they kind of use it. And I'll show you what it is. So the pale nuclei, unfortunately, don't show well. Oh, they show better on the screen. But this is a tumor that I've stained with Ki67, and it has a fair amount of positive cells. And you can take advantage of just pi r squared. So you count all the nuclei in a straight line, all of them. in the middle of the circle, like your microscope field, from one end to the other. And this becomes your diameter, how many cells. And you want to find an area that's pretty cellular and uniformly cellular. You divide that by 2 to get the radius, and then you use the formula of a circle, pi r squared, and calculate that number, which is an estimate of the number of cells in the circle. Then you stay in the same field and count the number of positive cells, and there you go. So in this example, there are 18 nuclei in the line, more or less. So the radius is 9. The total number of nuclei would thus be 254 by pi r squared. And there are 90 positive cells, so the index is 35%. You're supposed to count 500 cells, so you want to find an area with a, quote, diameter of around 26 cells to get yourself there. But it works very well. When fellows and I try it in tandem, we come up with very similar numbers, so it's cool. All right, let's go back now. We're in neuroendocrine tumors in the stomach. You got to know how to diagnose autoimmune gastritis versus the other types. I happen to be obsessed with autoimmune gastritis. It's all I think about, which means I am colossally weird. But in autoimmune gastritis, the intestinal metaplasia tends to be in the body, whereas in H. pylori associated, it starts out in the transition zone between the antrum and body, slowly fills the body, and then starts percolating, slowly fills the antrum and starts percolating up into the body. All right, so this happens to be a license plate that my colleague Rhonda Yantis provided for me that stands for autoimmune metaplastic atrophic gastritis. Although the preferred terminology is actually autoimmune gastritis, but come on. All right, so this is what normal stomach looks like. Yay, we can do this. You can see all the parietal cells below in the gastric body. Here are the foveolar cells, and of course the lamina propria hangs out between them. Okay, no problem. But in autoimmune gastritis, the parietal cells are gone by autoimmune injury. There happens to be pancreatic metaplasia here. And we also call it pyloric metaplasia because it looks like the antrum. And over on the left, we have intestinal metaplasia. This is essentially always of the complete type in autoimmune gastritis. In other words, there's a brush border and goblet cells, so it completely mimics intestine. All right, so if you have early autoimmune gastritis or H. pylori gastritis, in the H. pylori on the left, looking beautiful, is top-heavy lamina propria inflammation, whereas you tend to have more bottom-heavy chronic inflammation in autoimmune if you have a biopsy of the gastric body. All right, so this is an example of another net from the gastric body, and you can see it flanks the epithelium, or the mucosa and the submucosa. And if we look at the adjoining mucosa, it's completely lacking in parietal cells, which have been damaged by autoimmune injury. And this is a very, very nice picture. You can see from this endoscopic mucosal resection, where there's India ink tattoo in the submucosa, the background flat mucosa even has little baby endocrine cell nests. That's our enterochromaffin-like or ECL cell hyperplasia. And often you can pick these out on H&E if you look. Okay, what happens if you get asked to do the recipe? Count the Ki67 stain. Once in a while, in one of these so-called type 1 carcinoids, you'll get a big number. There will be a lot of staining, but these are still not going to metastasize. And do remember that metastases are rare for so-called type 1 carcinoids associated with autoimmune gastritis, and deaths are truly, truly exceptional. All right, so when does it stop being ECL cell hyperplasia and become a little baby carcinoid or a well-differentiated neuroendocrine tumor of ECL cell type? God, that's a mouthful. There's a huge literature on this of absolutely no practical value. Some people use a cutoff of 0.5 millimeters to call it a carcinoid, and I'm just going to use that terminology because I'm old. The WHO in the last edition wasn't terribly clear on a cutoff size. For me, if the endoscopist sees a nodule, it's a carcinoid, and if they don't, it's probably hyperplasia. It doesn't matter. It's not going to hurt the patient. It's a nuisance in the setting of autoimmune gastritis. Let's look at another case. Slide A is from the duodenum and B is from the stomach. Here we go. Here's A, we're in the duodenum. There's a little bit of gastrocerebellar metaplasia. You see that all the time, as you know, in injured duodenum. And there's the neuroendocrine lesion or neoplasm. Here it is at higher magnification, looking very neuroendocrine. We all know what that looks like. And here's the stomach one. Okay. Looks neuroendocrine, but a little different. And there it is at higher magnification with those beautiful salt and pepper nuclei. All right, this is a gastrin stain in the duodenal lesion. And here it is in the stomach lesion. And I think there's nonspecific staining in plasma cells, but you'll have to believe me that it's negative in the lesion. So this is the so-called type 2 carcinoid. And it results from hypergastrinemia from a gastrin-producing neoplasm, which often arises actually in the duodenum, not the pancreas. And this causes stimulation of the enterochromaffin-like cells in the stomach, and then you eventually get a tumor. So same idea as in the setting of autoimmune gastritis with a different mechanism. And these are usually indolent, but data are limited because they're super rare because we're talking Zollinger-Ellison. All right, so this is an example of a very, very teeny, dainty, pretty little duodenal gastrinoma. It's a butcha baby. And there it is on the H&E. You can see we're in the duodenum. And here's the gastrin stain. And sometimes a teeny weeny little thing like this is a separate patient or example from a patient with MEN1 with a gastrinoma of his or her duodenum. Okay, it's pretty tiny, although they had to do a resection because there was an intussusception. You can see it's a bit ulcerated on the top. And here is just part of an enormous lymph node to which it metastasized. There is a literature on primary duodenum, lymph node gastrinomas. I know that colleagues here have published on this, and their data look like that it really exists. But often you will find an itty bitty duodenal lesion if you have something like this, and you need to look for it before you make noise about a primary lymph node gastrinoma. All right, what's a type 3 gastric net? Okay, here there's no autoimmune backdrop, there's no Zollinger-Ellison, no gastrinoma. So in other words, no hypergastrinemia. These are a bit aggressive, and about a third of patients die of disease and a lot of metastases. Remember, you basically don't see any bad outcomes with the type 1s. That's the type associated with autoimmune gastritis, and the data remain poor on type 2. All right, so here's such a case. You can see that there's an identical lesion. You can see there's pristine oxyntic mucosa in the background at high magnification on the upper right. And then this lovely net in the middle or on the lower right. And these have a tendency to have a grade 2 proliferation index. So there are a few wrinkles. So we've already established type 1 carcinoids are indolent, type 2s are probably indolent, and apparent type 3s are bad, but there's a subset. There are some patients who've been taking proton pump inhibitors for a jillion years, 20 years plus, and they get these lesions. And they're indolent, like type 1 and type 2. I've given you a couple of references. And some people call those type 5. Wait, where'd 4 go? Huh? So the 4 type is really, really rare. I think I have seen 2. So they don't exist often, but they're very distinctive. These are patients who have hypergastrinemia related to defects of acid secretion by parietal cells. And the general idea is they have an inactivating mutation of the gene that basically encodes the proton pump. So it's as though they're born on massive doses of proton pump inhibitors because they ain't got no acid secretion. And here's such a case from the long-term proton pump inhibitor situation. And you can see there's intact oxyntic mucosa and this little guy here. And I don't think that's intestinal metaplasia. I think it's reactive. Don't do a P53. And here that is at high magnification, a little reactive stuff around the lesion, but intact parietal cells. And you really do see the proton pump inhibitor effect very well. And here's a chromogranin from that particular case. And you'll notice in the image at the bottom that, in fact, there is enterochromaffin-like cell hyperplasia in the adjoining unremarkable appearing oxyntic mucosa. And here that is at higher magnification. We're trying to get a little of nodular, meaning it makes a nodule, not quite, and certainly linear, at least 5 or 6 stain cells in a row, indicating hypergastrinemia. Now, let's look at some stomach biopsies from a very young woman. That means younger than me. And she does not take proton pump inhibitors. She does not have antiparietal cell antibodies. She does not have intrinsic factor antibodies, i.e., she doesn't have autoimmune gastritis. And look at her gastrin, it's 560 as opposed to around 50, which is normal. Okay. Does she have a tumor? Let's look hard and long. No. All right. And here is her little lesion in oxyntic mucosa that's more or less intact. Plenty of parietal cells, so she can't have autoimmune gastritis. And here is some of her surrounding flat mucosa. Okay. That looks okay. But as you go on high magnification, you can see that there is a lot of enterochromaffin-like cell or ECL cell hyperplasia, and you can even see a pretty big nodule on the right. And interestingly, there are a bunch of bacteria even in that oxyntic gland. There shouldn't be bacteria in there, right? They get killed by the stupid acid. And these aren't H. pylori, they're just like junky bacteria. Well, her acid just isn't being produced. All right, so she probably has a type 4 carcinoid and probably her proton pump doesn't work. I was unable to get her to be tested for the germline mutation, basically because it's really expensive and she didn't want it because it's an autosomal recessive inheritance, right? So, it's probably not all that helpful for her children to know, but I believe that that's what she had. So I hope you'll enjoy this table that took me a while to compile, but it shows expected gastrin levels with the various situations I've just discussed. And you'll notice that even with the type 1 carcinoids, the ones from autoimmune gastritis, the gastrin can be pretty high, and naive surgeons will then think they need to explore for a tumor, and you have to explain to them, no, 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 dear. This is all fine. This is expected with autoimmune gastritis. And my colleague Julio Poveda wrote a very nice paper on, oh my goodness, all the different weird morphologies you can see in the type 1s. All right, so the flip side of endocrine hyperplasia is foveolar hyperplasia. So we see oxyntic hyperplasia in Zollinger-Ellison because of the gastrin making the parietal cells go ape. And this even has an erosion. And then, of course, we get foveolar hyperplasia in Menetrier's disease, as seen on the left. So this is a beautiful Menetrier disease. I don't know if any of you have had a chance to see it, but it was called hypertrophic gastropathy, giant fold disease. And these patients have these, giant folds, as you can see, and they pour out mucin. And it pours out and pours out to the point that they get hypoalbuminemia. And of course, under the microscope, they have foveolar hyperplasia that just presses down the parietal cells. And so they have hypochlorhydria. So the cute thing is in Pierre Menetrier's initial report, he in fact likened the gross appearance to that of a sectioned brain. And I would certainly agree with him from this image that's from the late Dr. John Yardley. And here is something from his original paper describing the condition that now bears his name. He probably had more than one entity in there, but there is an entity in there. And the title of the paper was Concerning Multiple Gastric Adenomas. So he called this foveolar hyperplasia adenomas in relationship with gastric cancer. And there was a bigger one in his day than there is now. And this is a beautiful Menetrier gross, and you can see the key. The antrum is spared. So if you get biopsies and the colleague says, Menetrier disease, and there are 5 biopsies from the antrum, you don't have the information, and you have to be a little bit schoolmarmish with the gastroenterologist. That's another handsome man, Dr. John or Jack Yardley, and I got this picture from him. He is now late. All right, this is actually a diagram from Menetrier's original paper. Isn't that cool? And it really shows all the bits. You can see the pits, you can see the squished down glands, and the foveolar hyperplasia. Isn't this gorgeous? or I think it is. All right, and this is a case on the hoof, and you can see the massive foveolar hyperplasia, and you can see the that you can't even really see the parietal cells here, but it affected the body. The trouble is that if you had a little biopsy from like up here, you'd say it was a hyperplastic polyp because you can't tell. You have to know what's going on. All right, and of course there are molecules involved, and this process seems to overproduce transforming growth factor alpha, TGF alpha, to account for all the stuff you see. And in fact, you can target it with the same stuff that you use for EGFR, and that was first noted in around 2000. And so now it can be treated with targeted therapy, basically using the same stuff you use for breast cancer. Erbitux is what it used to be called. More on that in a bit. All right, gear switch for my favorite thing ever. Big gastric body polyp in a 72-year-old woman with a long history of my favorite thing, autoimmune gastritis. And here it is. Very, very closely packed tubules. Some are rolling their eyes, I'm sure, because I'm obsessed with this. And here it is at higher magnification. We have mono layers of nuclei, and then we have this kind of ground glass cytoplasm. And this is, of course, my favorite thing, pyloric gland adenoma. It's a harmless obsession. So I'd like to make a few comments on gastric adenomas and dysplasias before the gong sounds. So what about gastric adenomas in a population? The terminology is a little bit misleading. There's so-called intestinal type, and basically it's polypoid gastric dysplasia with intestinal differentiation, because it basically always occurs in the background of gastritis, intestinal metaplasia, cycles of damage and repair. There's the foveolar adenoma, and those are probably the true adenomas. There's the pyloric gland adenoma, and it has GNAS mutations, whether it's gastritis associated, autoimmune gastritis associated, of course, pyloric metaplasia, pyloric neoplasia, or whether it's FAP associated. And then there's a newer one, the oxyntic gland or chief cell type of adenoma. And European colleagues have actually, because they love to use the word lesion, no matter what the thing is, have moved to regard gastritis associated things that we're in the habit of calling adenomas as lesions rather than adenomas, because of course they are polypoid dysplasia, just like in colitis from multiple cycles of damage and repair. So the trouble that makes it confusing is that, for example, if we see a polyp with pyloric gland differentiation in the setting of autoimmune gastritis, well, then it's not really an adenoma, right? It's gastritis-associated lesion that's neoplastic, blah, 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 blah. Whereas the same patient with familial adenomatous polyposis and pristine mucosa, then the same lesion is called an adenoma. But it's like we're used to saying tubular adenoma in the colon or, colitis-associated polypoid dysplasia. So the concept is the same. We're just not used to it in the stomach. And same thing with intestinal differentiation and gastritis versus just in pristine mucosa being an intestinal adenoma. So this will get sorted out eventually, but it didn't yet. All right, so this is a great big stomach polyp. And let's take a look at it. A little higher magnification. So far, the flat mucosa doesn't looks like we're in the antrum. Maybe we're transitional though, because I think a few parietal cells here. Okay. And here it is. And I could tell you this was a colon adenoma with high-grade dysplasia, and you'd be fine with that, but it's a stomach adenoma with intestinal differentiation and some high-grade dysplasia. We're in the habit of calling it an adenoma if it makes a polyp. On the other hand, you can see that the adjoining mucosa right here. Okay, let's see. Come on, Boiner. Come on. There it is. Okay, you can see that there's a little bit of intestinal metaplasia in the adjoining mucosa. It would more or less be the complete type because there's a brush border between the two cells. Hilariously, it's the incomplete type that's supposed to progress, but minor detail. And here is another one. This lesion formed a polyp, looks like a tubular adenoma. in the colon, except that underneath you can see gastric mucosa, so you know you're in the stomach. This one was also in the antrum. And here's the background flat mucosa, which has plenty of intestinal metaplasia of both the complete type without foveolar cells in between and of the incomplete type with foveolar cells in between. That's the type that's supposed to progress. And here's a PAS Alcian blue. I just did it to illustrate the types of intestinal metaplasia. In the next year or so, the gastroenterology, the American College of Gastroenterologists will tell them that they need to know which type in the stomach. So they'll start asking. You can tell very easily on the H&E, and you really don't need to do any stains. And just a little bit of the complete type, the stuff on the left, is not supposed to require surveillance. This is the true stomach adenoma. This is a gastric foveolar type adenoma. Pristine mucosa in the background and low-grade dysplasia. Strictly foveolar, no goblet cells on top. This is really truly like a colon adenoma. So C of normal in the background, boom, a couple of mutations did the job. And that happens to us in our colon, but it doesn't happen very often in the stomach. This is such a case. Here's the surface. The nuclei are a little bit big, and you can see that there is foveolar differentiation, not a goblet cell in sight. You don't need to do a PASAB, but isn't this cute? Would you? The pyloric gland adenoma is about 3% of all gastric polyps after you take out the fundus gland polyps. So it's really very infrequent. And it tends to be more common in women, and you tend to see it in the setting of autoimmune gastritis. It can progress to cancer. Quite frankly, it usually doesn't. And then, of course, it can have GNAS mutations. And the defining series is by my European friend, Michael Feet, in Germany. So here's how they look. Monolayer of nuclei, tubules shoved together, ground glass cytoplasm. I never tire of them. And here's just another one, same sort of features. And if you do a PAS Alcian blue, you get this sort of smudgy foveolar differentiation, and you don't really get a crisp apical mucin cap. So they have their own appearance, if you will, on a PAS Alcian blue. And sometimes you'll even see a bit of intestinal differentiation in these. If you want to do an immunostain, this one has a very interesting morphology in the MUC6. This one happened to be in the antrum. They tend to have co-expression of MUC5 and MUC6 in the lesion. Here you can see antral glands staining with MUC6. You usually don't need to stain, but it can be fun if you're struggling. All right, so just a swimsuit contest. On the left, we have our foveolar adenoma with nice apical neutral mucin caps, usually on the surface. And on the right, we have our pyloric gland adenoma with this kind of ground glass appearance to the cytoplasm rather than crisply defined apical mucin caps. The last one is the oxyntic gland or chief cell adenoma, and they were first reported as carcinomas, even though there were no metastases. They have GNAS mutations. However, some of them really do turn into cancer. Some of them really do metastasize. They're just very low grade. And there are very limited number of metastases to date, but they're unlikely to kill the patient. And in fact, some Japanese colleagues said, well, why don't we call them oxyntic gland neoplasms and use the malignant terminology only if the process looks atypical and invades into the submucosa, and call them adenomas for the ones in the lamina propria. So it's not really an intellectual solution, but it's a practical solution. So let's see how they look. So there's one here at higher magnification on the left with these weird angulated glands. Usually the surface is uninvolved. And here's this lesion, this oxyntic gland adenoma or neoplasm, however you like to call. And the angulated glands catch your eye and frighten you, but on high power, they're not particularly exciting. And here's another example, looks scary. Mostly chief cells, but you'll see that there are a few parietal cells hiding in there. I don't know if they're entrapped or an integral part of the lesion, but I think they are an integral part, not sure, no way to prove it. And here's one that really just looks pure chief cell, very cute. And if you are struggling, these express MUC6, just like pyloric gland adenomas, so that doesn't help you. But if you do Ki67, they usually have a very low proliferation index. And if you do a PAS-AB stain, you really don't see any staining in oxyntic gland adenomas, but you see you have that nice surface as your internal control. This happens to be a MUC5. So if you have one and you're struggling, they're negative in oxyntic gland neoplasms or oxyntic gland adenoma, depending on your favorite terminology. And here's the MUC6 from the one I just showed you. There is a pitfall, and that is their tendency to stain with synaptophysin, but luckily not with chromogranin, should you get one of these. And they can occasionally go bad. So this one is just beginning to dip its little toe into the submucosa. Endoscopic resection should be curative, though, as you can see with your own eyes. And here it is at higher magnification, and this is genuinely atypical with mitoses in the lesion. So a few of them are indeed naughty. This is an interesting case, kind of segueing from the same idea. This is an adenocarcinoma, or at least in my opinion, and this was very aggressive. And to me, it looks like it has similar differentiation as oxyntic gland, if you will, adenoma or neoplasm. I'm not really sure. It has a different growth pattern. And here's MUC6 on that. And of course, as you can imagine, there are plenty of gastric carcinomas that have unusual differentiation, which I'll talk a little more about in the next session. Okay, another case to make fun of myself. A biopsy was performed of a gastric polyp, and I diagnosed it as a hyperplastic polyp. And the gastroenterologist could not stop laughing when she called me to point out that my diagnosis was wrong. And I was extremely appreciative of her altruistic assistance in this matter so that I could amend my report. And here it is. So Dum Dum here called this a hyperplastic polyp. The smooth surface should have been a clue to me to do a better chart dig, but I didn't. Nope, not me. And here it is at higher magnification and through the retrospectoscope. Of course, I noticed this band of smooth muscle in it, which I had attributed to the erosion that you can see at the bottom and prolapse changes. And this was a gastric Peutz-Jeghers polyp, and I would screw this up again tomorrow. Which is unfortunate. So, of course, everybody knows that PJ polyposis is an autosomal dominant condition with characteristic germline mutations. And I think everyone remembers that there is distinctive melanin pigment around the lips and in the mucosa and around the eyes. In other words, places where you don't usually see freckles. And of course, it fades with puberty. So when you get an adult, you're going to go like this and try to find the pigment inside the mouth. Now, I don't want to get my spit on the keyboard, so I'll try the other hand. So this is a child on the upper left with very pale skin. It's easy to see the pigment around the child's lips and kind of cascading onto his face. But with the child on the lower right has brown skin, so it's harder to see it. But the colleague was smart enough to turn his lip up so that the pigment could be seen. This is a stomach that had to be resected basically because it didn't work in a patient with Peutz-Jeghers gastric polyposis. So in contrast to the small bowel, where you see that beautiful arborizing smooth muscle with the extension to the submuscularis mucosae, the stomach ones, you don't have a prayer. So you're going to screw them up unless somebody tells you the patient has a history, which is really distressing. But once in a while, a stomach one will do exactly what it's supposed to do with these cords of smooth muscle partitioning bundles of site-specific mucosa, and then you can suggest it. But most of the time, you will have no stinking idea in the stomach. Here's the one that I messed up. Good job, me. And through the retrospectoscope, sure, I should have thought of it, but I didn't. And it was a fairly young patient, and usually super young patients don't have gastric Peutz-Jeghers or gastric hyperplastic polyps. And there it is. On the other hand, of course, usually the small bowel ones are very easy to identify, and I just wanted to show off this beautiful picture. And of course, we look for that arborizing smooth muscle, separating site-specific chunks of mucosa with lamina propria. Juvenile polyposis, it's heterogeneous. There are several sorts. And of course, the key mutation, if you're lucky enough to have loss of it in the stomach, is SMAD4. And the patients who have only stomach involvement of juvenile polyposis tend to have germline DPC4, SMAD4 mutations. Often the polyps are in the colon only. Sometimes they're in the stomach only. And of course, we can see these. So here's a nice example. Again, a gastrectomy had to be performed because there was no way to safely monitor all these polyps, which can progress to cancer. And there's a clue with these syndromic polyps, and you don't always get it, but notice how smooth the surface is. And I don't know why, but syndromic polyps in the stomach, if there's not gastritis, tend to have a smooth surface. It's not hard and fast, but it worked very well in this case. And we see the same sort of things that we see in the stomach. But this is a regular one. I can't tell this from a hyperplastic polyp. And this was a patient known to have juvenile polyposis. So unfortunately, we're going to stink. This is a montage showing a case in which I was very fortunate. The patient had a bunch of stomach polyps, and I noticed a peculiar pattern of what I thought looked like gastric differentiated dysplasia in one of them, the one at the left. I ordered a SMAD4, and to my delight, there was loss in the dysplasia, unfortunately not in the non-dysplastic epithelium. And so not only could I say, oh, this is a juvenile polyp with dysplasia, but here's what kind. But you don't get that lucky very often, which is why I had to show you the picture. But when you do, you feel like a real smarty pants. All right, how do you tell the difference between a gastric hyperplastic polyp and a syndromic one? It's really embarrassing, knowing that the patient has the syndrome. If you're lucky, the flat mucosa is pristine, and that's your key to think of it. And there's this theory about a smooth surface of syndromic polyps. Doesn't really work that well, but sometimes it's a clue. So this is sort of a classic antral hyperplastic polyp in a patient who'd previously had H. pylori, and you do have these little globby villiform projections. Just a clue, though. You have to dig around in the chart. Isn't that great? All right, FAP, very common amongst polyposis syndromes, and it's systemic. And they have intestinal polyps and a bunch of other stuff. Here's some of the other stuff. This poor patient has a lot of epidermoid cysts around his neck. And of course, there's the retinal pigmentation. They have germline mutations, and it's autosomal dominant. So everybody knows about this. Hopefully, everybody's seen one of these with just carpeting of polyps and FAP. And sometimes there's a mutation off of the typical range of mutations, and then there are fewer polyps, but it basically is all managed similarly. In the upper tract, they all get fundus gland polyps if you follow them long enough. Of course, if you see the biopsies when they're kids, you might not see anything, but by 20, most patients with FAP have a fundus gland polyp. They do get adenomas, and they start to get gastric adenomas when they're young. Median age is in the 30s. They do have a small but real risk of gastric cancer, but it's far lower than, of course, their colon cancer. And of course, if the patient has fundus gland polyps and they have FAP, you'll see surface low-grade dysplasia in about a quarter of patients. Usually it doesn't progress into anything. They can also have syndromic pyloric gland adenomas, and they look just like the ones that you would expect to see in anybody else, except often in our population, there's no background gastritis. You can see pyloric gland adenomas in Lynch, which was kind of a surprise for me, and in McCune-Albright syndrome. So this looks just like a pyloric gland adenoma from anybody else, but it came from a patient with familial adenomatous polyposis. And just, I mean, you can't tell this from a sporadic one. So just to remind us, in theory, you can tell them apart on H&E. Generally, in a PGA, the surface is uninvolved or a little bit involved, and it's underneath. And of course, this is all foveolar cells in the hyperplastic polyp. There is a subset of FAP in which we see gastric adenocarcinomas. There's a very, very specific mutation that's way off to the side. And this is an example of such a case. It's called GAPS, and it's a variant of FAP. And these patients have a jillion fundus gland polyps all over their stomach. Here are some images from a patient with known GAPS. Look at the original paper when the point mutation was found. There are way more authors than patients. And the patients have all these fundus gland polyps. And then they have these polyps with gastric differentiation that are adenomatous. And here's such an example. This looks like a regular old fundus gland polyp, except the patient will have 84 squillion of them. And of course, in this patient, there's also an adenoma with foveolar type differentiation. And here it is at high magnification. Look at those gorgeous apical mucin caps. All right, here's one that's starting to invade in GAPS. What about Lynch syndrome in the stomach? Guess what? They get almost the same stuff as folks who have familial adenomatous polyposis, just fewer of them. We were shocked. We just went through a whole bunch of patients with Lynch, and darned if that's not what we found. Basically, looks like FAP, except fewer of the various polyps. Here's an example of somebody with Lynch. It doesn't show well at low power, but there's an early cancer here. There's an adenoma with foveolar differentiation there. And this is the MSH2. It's lost in both the precursor and the postcursor. Here's a higher magnification of the postcursor. And this is just to show loss of MSH2. I hope it shows, yes, on the left, the precursor, and on the right, in the postcursor. Kind of cool. All right, we've seen a lot. We've talked about gastritis and that it strongly informs the type of stomach polyps we might see. We discussed syndromic gastric polyps. We talked about the key types of adenomas. And my favorite topic, endocrine cells, neuroendocrine cells. So just a little summary of what you might see in the flat and the polypoid mucosa, as we've discussed. And I draw your attention to the foveolar type adenoma. Usually has normal background mucosa, but many other of the lesions has a background of abnormal mucosa. Thank you. Monica, how do you want to work? Just directly segue? One or two? Okay. No? Okay. Are there any burning issues in the stomach while she puts up the other one? Yes, ma'am.
I'm Monica from New York. I wanted to ask you, what is your criteria of using SMAD4 immunostain?
What are my criteria for using SMAD4 in gastric polyps? I only bother if it looks like there's dysplasia, because you won't see it lost in non-dysplastic. Oh, I see the question. So as the colleague pointed out, in adenocarcinomas and high-grade precursors in the pancreas, actually usually not, you see loss of SMAD4 around